Sairam sir. I am very much thankful to Dr. Professor Kalangus sir and Sean Shetty sir for giving me this opportunity to discuss a few aspects of drug dependent lesions, PDS stenting in a humanitarian setting. I am pediatric cardiologist, started my journey in this divine mission since 2014. On 31st of January, we had our first exclusive pediatric cardiac OPD. This is the hospital where we started as a team. This is Raipur Hospital under guidance of Dr. Sri Srinivas sir, chairman of our hospital group. And it is a divine mission, Sri Sathe Sai Baba, who started this free heart care program and ably being taken forward by Sadhguru Sri Madhusudan Sai. We also have this beautiful Center for Human Excellence, that is Sri Satya Sai Saubhagyam, right on the right side of the screen. Just introduction about our working at Sri Satya Sai Sanjeevani Hospital, not only Raipur but also Palwal, Mumbai, Kharghar. We have this Ashraya screening block where we have loads of patients and many of our volunteers and our working staff, they do screening of children who have congenital heart disease. Non-cardiac patients are helped to go to other centers. Only those are screened inside. Now on the right hand side, they are waiting for their turn for getting X-ray, ECG and echo consultation done. In OPD, over last 12 years, we have seen steady increase in number of OPD echos done. In the numbers, it amounts to 6,000, 7,000, 9, 12. We have definitely stabilized around 25 to 31,000 last year, and we will reach that 31,000 figure this year also. Every day I have OPD of around 100 to 120 cases in the beginning of the week. So Monday, Tuesday, Wednesday is the heaviest of the days, and it slowly wanes off to Saturdays. It also sees 80 patients every day. All are congenital heart patients. Some are rheumatics or cardiomyopathies or some unfortunate children. But number of surgeries we perform, we started with around 500 in the first year of our operations, and we have a steady 100 to 1200 surgeries happening every year. This year also 1100 surgeries and one more month to go. So we will reach around 1200. Cath lab started a little later, and 2017 we had 9 cases for the inaugural run, and then steadily we have this number maintained around 700 to 1100 cases every year. So with this heavy workload at our center, I have seen, I am fortunate that I am since day one of this exclusive pediatric cardiac care health mission. This is our divine mission, I consider. And I have seen not only the simple ones, VSDs, ASDs, PDS, but also complications of those VSDs, long-standing VSDs, like subaortic membrane, double chambered right ventricle, aortic wall regurgitations happening, ruptured sinus of Valsalva happening. Not only those simple VSDs, acyanotics, but also all range of cyanotic heart lesions, all the T series we call the terrorist series for infants and neonates. Not only those described in textbooks, but also we have seen lot of such wonderful, amazing combinations. Unlucky for the child and the parents, but then we come to this line: he doesn't refer textbooks to create, but texts are written after we study his creations. So that is what I have learned over last 12 years of working here. Now coming to ductus arteriosus, it is a vessel which connects the two circulations, and it allows bypassing of lung system to enter the descending aorta. That is what is there in fetal life. But at the fetal to neonatal transition, it is expected that within first 12 hours, definitely it will have a functional closure, and anatomical closure will happen over next 2 weeks. If it remains it persists shunting, then it is called persistent ductus arteriosus for initial 14 days. But beyond that, it is pathological and considered to be labeled as patent ductus arteriosus. But in certain congenital heart diseases, it can be a catastrophic process. We have these ductal dependent lesions which can be simply classified as systemic circulation dependent on the ductus, or duct dependent pulmonary circulations, or obligatory mixing, and transposition of great vessels is the perfect example of those things. This is the diagrammatic representation of these duct dependent lesions. Hypoplastic left heart syndrome, which is the commonest of the lesions being treated in western world, but sorry to say, here in India we have very less centers which can confidently and organized way deliver lifelong treatment for hypoplastic left hearts. We do get critical valvular aortic stenosis or critical coarctations, which we have been doing treatment in our cath lab, and we have got good results. Pulmonary atresia intact ventricular septum is a totally different substrate, and it needs diagnostic cath and then further decision whether to intervene or not by doing a shunt, because if it is RV dependent coronary circulation, then they may pop off if we put a shunt into it. So knowing all these duct dependent lesions, we need to understand one thing: the circulation, either systemic or pulmonary, is at risk if PDA closes. So it may be a cyanotic child or a cyanotic child, and the clinical presentation always is like poor feeding, irritability, lethargy, but finally they all end up in severe shock, whether it is systemic or pulmonary circulation. So medical stabilization is the first thing by maintaining patency of the ductus by prostaglandin infusions. Use of oxygen is a tricky phenomenon. It may close the ductus which you have opened with prostin, so we generally try to avoid it. But historically, surgical shunt, conventional shunt surgery has been the standard care in palliating such unlucky children. Infant mortality rate in India, it began since 1900 in higher 200s, but over these many years it has been slowly declining, and now it is 25 in 2025 as per the latest numbers. Infant mortality rate is world over considered as in best of the facilities available. It reflects critical congenital heart disease related mortality. So I considered IMR as the indirect indicator of CCHD related mortality. So this conventional shunt surgery was devised by mother of pediatric cardiology in the center, Helen Taussig, and done by Dr. Alfred Blalock and his assistant, Sir Vivian Thomas. So we call it Blalock Taussig Thomas shunt. It's a milestone, and luckily it was done. Today is 28th of November. Exactly 81 years back, first surgery was done successfully in John Hopkins University with these three greats, and they have pioneered the congenital heart disease surgery and shown to the world. It was called as a color changing operation that time, and so many modifications of that classical BT shunt has now undergone over further decades, 50s, 60s. So mortality and morbidity also changed from initial 25% to 15%, then 10%, but it has remained around 7 to 8%. I think over the last 2 3 decades, because there was no further decline in mortality, because many centers took it up, or various permutations and combinations, but there was a growth of interventional techniques to augment this pulmonary blood flow called as stenting of PDA. So the word stent, we can discuss this. This is the Krichenko classification of patent ductus arteriosus, type A to type E, conical classical, the window PDA, kissing ductus it is called, tubular PDA, complex tortuous PDA. That is what is usually the case for any VSD pulmonary atresia settings. Type E is elongated PDA. Also, fetal or type F PDA is also one which is now in quite a common use, type F PDA. So historically, Charles Thomas Stent, he was a dentist and he used to create a solution to help his dental prosthesis to stay there. So it had multiple uses. It was taken over by other non-cardiovascular uses also, in addition to dental uses. In cardiovascular, peripheral vascular, and then coronary uses were also taken up. The first use of stent, not as a word but as a noun, stenting, was done by Charles' daughter. It was a preliminary report of nitinol stent grafting. But then Sigvart gave that first report of use of stent in sudden occlusion prevention and restenosis occlusion abbreviation after transluminal angioplasty. That was the first report in New England Journal of Medicine in 87. The other two groups also took it up. So 87 and 88, it really commercialized the stenting business in coronary systems. For PDA stenting, our history goes first to Gibbs et al., who had attempted PDA stenting in infants way back in 92. Unluckily, because of some non-cardiac issues, pneumonia, sepsis, these two unlucky children could not make it. But the first widely successful significant series of PDS stenting was reported in 2004 by Sir Shakil Qureshi, who was that time working in Malaysia Hospital, Kuala Lumpur, with Khalid Alvi sir. And this series led to re-evaluation and wider adoption of the technique globally. So now here we come for ductal stent discussion. The indications are well established, and pulmonary atresia with VSD or intact septum, critical pulmonary stenosis or hypoplastic right ventricle due to either tricuspid atresia or similar single ventricle scenarios. Hypoplastic left heart becomes another one different subset of patients, and complex single ventricle physiologies. All are indications for ductal stenting. Contraindications being size less than 1.5 kg, high tortuosity index that was given by Alviser in his that landmark paper. Pre-existing peripheral branch PS stenosis is also one contraindication, as also the narrowest PA end of the ductus. Some papers say more than 2.5, some more than 3. So we need to go with this equipment for ductal stenting, all the catheters and stent delivery, long sheath, guide wires. The commonly used stents are coronary stents. We have used in Sanjeevani bare metal stents, but cost wise and also efficacy wise, the drug eluting stents are a better option, because in India now we have capping of costing. So if it costs around 7 to 8,000 for bare metal stents, the cap for drug eluting stents is sirolimus based is around 28,000. It roughly counts to around 20 to 80 US dollars for drug eluting stents. It is quite a good option for these children, because for US, in various publications and some references, the cost for PDS stenting is a staggering 1 lakh to 2 lakh, and the whole BT shunt related costing is also given in this reference as early as 2019. It is reported around 2 to 2.5 lakhs US dollars. Definitely in India we have less costing, but then there are quite a few challenges in humanitarian settings. On the right hand side, we have huge numbers of beneficiaries who really need these type of shunts, life-saving shunts. But we have limited resources, we have limited manpower, limited facilities, infrastructure. So in infrastructure, I mean to say these exclusive pediatric cardiac. If we have seen over years, because I started from Cherians I have seen you, sir, when you used to visit Chennai, Professor K.M. Cherian sir's place. I have done my pediatric cardiology there. But then I have seen, after I came to Sanjeevani Fold, I have seen exclusive pediatric cardiac work, dedicated pediatric cardiac work means a lot for children. If we mix adult and pediatric, definitely interest for pediatric dilutes. Various factors are there. So we want dedicated pediatric cardiac centers. What I was meaning to say, in limited infrastructure and limited facilities, limited finances, yes, definitely we have limited finances and limited access to care. India being a huge country of around 140 crore population, we need to have more centers. Anita Saxena madam's paper from All India Institute of Medical Sciences uh, in 2019, it says just over 20 years, initial 10 centers at the beginning of 2000 has increased to 40 centers, but they are not exclusive pediatric cardiac like Sanjeevani system. They are mix of adult and pediatric. Many are corporates. Government centers are also having adult and pediatric, but the concentration goes over to adult side. Pediatric lags behind. So I want to emphasize we need to have exclusive pediatric cardiac dedicated centers for catering to these masses, because every day I see, when we started the orientation and the people's awareness, pediatricians awareness to refer was very less. First 2 years I have seen, I used to see these critical congenital hearts once or twice in a week. But now, every day I see one critical congenital heart, or every week we can say 10 to 15 critical congenital heart. And as we discuss further, we don't have that much of our resilience and buffer to cater to needs of all of them, because every child has a right right to health, and UN Convention for Rights of Children Article 24 has a key provision. They have the right to enjoy the highest attainable standards of cardiac health also. So it is our duty to each of the child who enters our consultation chamber, our eco room, that we should be able to offer to him whatever we can. Like I have learned from KM Cherian sir, he will definitely offer whatever best possible he can offer. So I also have inherited that legacy. So coming to this topic, sir, natural history, if we look into these drug dependent lesions, they are predestined. If we cannot do much to them, they are predestined to meet their natural fate. Mortality rates are high if left untreated. So we need to have innovative solutions. In this humanitarian mission, if we now have a historical timelines with us, first shunt surgery started in 1944, 81 years before exactly. Multiple modifications to that over next 60 years, and beginning 2000s, we have got this very glamorous alternative called PDA stenting, but it is not much in use in India, at least in this humanitarian mission, which we need to look into it. Lots of pros and cons. Benefits are, it is less riskier if in trained hands, if in accomplished and regularly doing hands. Lesser morbidity, yes, definitely. No surgical scars, and definitely when child meets the first stage, it is a first case, not like previous BT shunt and then going for BDG or further steps. Yes, it is a breach to next stage surgery, but there are risks. If something happens, acute stent dysfunctions, stent thrombosis, branch pulmonary artery stenosis, usually left, is quite a common scenario if millimeter by millimeter shunt placements are not followed properly. These are various references for that. The contraindication, as I was mentioning, These two are contraindications constantly given by all the things, all the review of literature. The commonly used stents are bare metal stents and drug-eluting stents. Biodegradable ones are not reality for us. It's still. I remember came Cherian sir telling me about your mitral clips, the biodegradable clips. Yes, yes, biodegradable rings for mitral valve repairs, the percutaneous way inside the coronary sinus length. So similar, just I want to discuss the comparison between shunt and stent. Lot of literature is there available uh, from CCR collaborative, and we have this compass trial which will come up with final conclusions in 2026 projected, but then definitely the results are not inferior for PDS stenting, but BT shunt is a well established and time tested successful surgery. We need to have a very comparable alternative which can be replicated in multiple centers at multiple units with multiple operators. Ductal stenting, the procedure and techniques are the same which have been described with various ways of approaches of deployment, antegrade or retrograde, but we have technical challenges in certain scenarios, right sided aortic arch and ductus which is having tortuous bends, or the peripheral branch PS having origin stenosis. If we detect on table, we have to either back out or then try to circumvent it. Reasonable short to mid-term palliation results have been reported by various groups all across the globe. These are further review of literature, and we definitely have this very viable option of stenting the ductus. But then as we move ahead, this John Moore sir's review article in pediatric cardiology last year has been a landmark article I consider personally, because he has discussed all the pros and cons and right from the history. This Journal of JTCVS article in 22 also compares PDS stenting versus BT shunt, and this recent one from one group in Kolkata, ductal stenting in 88 children, which got published recently in Cardiology in the Young, that tries to discuss about use in resource limited settings for ductal stenting. So we need to have cost effectiveness, because we know there is short duration of stay and less morbid course if handled with a experienced and well organized team. Yes, access to care is unequal at present, but we need to improve on that. Costs of congenital heart disease care, for example, for hypoplastic left heart, goes in 2 to 3 lakh US dollars. For India, such centers are very few. At least 4 5 I can name. For India, we need to have these humanitarian considerations that for catering to masses, we need to replicate and increase such hospitals like Sri Satya Sanjeevani Hospital Group, which now has 5 hospitals. We need to build up on such lines, exclusive dedicated pediatric cardiac work. And we need to engage the community where we are working. Like we are going to local camps, conducting diagnostic screening camps and building up the local network referral systems. Uh, on similar lines, like the Rural Shores Networking System by Murali sir, doing the rural networking. We also have to do maximum good to maximum number of patients in a humanitarian mission, with maintaining equity and equality to provide healthcare access to all. With this background, if we try to do cost effectiveness, definitely we need to address this by cutting corners, but quality of care can suffer if we approach this way. Competition for diseases to get funding, whether to accept collateral damage while providing treatment to maximum diseases. Then certainly these drug dependent lesions, single ventricles or biventricles who need this stenting and then go on further, these children get marginalized. And personally, we are trained as doctors to treat each and every child, to give whatever we can to every child. So I cannot discriminate. I would like to put stents, but then we understand the limitations of the mission we are working in. So we need financial resources, we need four M's: material, method, manpower, and definitely we need to devise certain methods to help maximum with minimum. So in that scenario, at Sanjeevani, we have the expertise, but limited team members. We have surgical backup, but then surgeons are also stretched out doing the surgical work. So with huge numbers in OPD on a daily basis, with less number of staff, we don't have actually that big a setup to cater for PDS stenting in present scenarios. So in that, because now since 20 years I have been in the field, I have this observation to ponder upon. A story of a palliated child. If a child has undergone fountain completion, every year he needs to undergo some bloods. Every 3 to 6 months, depending upon his individualized care, he needs to have echo, PT-INR every 30 days, physical activity restrictions on a daily basis. Child and his family can land up in narcissistic premons. In humanitarian missions, like Helen Auntie was saying, we need to help palliate them, nurture them, build up their tempo, make them continue in positive circle of life. And in this humanitarian mission, if we have to do maximum good to maximum patients and offer quality care with equality and equity, we doctors in Sanjeevani, where we uphold our medical ethics, morality, and treat with spirituality, we may not be able to offer 100% to every child who is coming. But we have no choice. Right now, we are stuck in that scenario. So, in future, we need lots of requirements, but I tried to write up a few better suited stands, better techniques, and more skilled staffing. That is the need of the hour. And yes, definitely, this ductal stenting is a step in the ladder of palliative heart care scenario as of now. This is what one PDS stent that I have pulled out from the archives and done at Raipur Hospital. That is the balloon expansion of the stent. Afterwards, one more stent had to be put, stent in stent. That is the final result. But then in humanitarian settings, there are different stenting options for single ventricle or biventricular repairs, for palliation, or if a child is biventricular but needs to get this bridge of life and then go on with better sized branch PS, then we'll have RVPA conduit in biventricular settings. Definitely, we will follow the contraindications to stentings, absolute or relative. Yes, coming to this, we need collaborations and partnerships from this August gathering of world over, all the experts in congenital heart palliations and treatments. We need collaborations and partnerships with all the senior groups, senior members, and more experienced than us to guide us, to help us build up our strengths in this PDS stenting. It's going to be a program and it's going to be a challenge. So hopefully with your help and your expertise, we can gain and we can accomplish these goals in our setups also, because we need long term follow ups, quality of life. We need to document the palliative care given, and with your templates available, we can definitely learn from your answer and we can reciprocate in replicate in our areas. The humanitarian organizations responses as well as the donor support that is vital to us. We need a continued sustainability in this stenting program. The capacity building, which is the heart of this program buildup, will be definitely guided by this August gathering. And community based medicine like Rural Shore, which was a networking app developed here since last 10 years. On similar lines, we need to have a constant supply of constant chain of networking of these community based workers who can guide those who are in need to the hospitals, because there is quite a inequality of infrastructure and healthcare addressed at various parts of India. There are a lot of research opportunities. Um, I can see over so many years, had we started off with the manpower that is needed for such a PDS tenting program, we could have had many groups as of now replicated in multiple centers, with each center having 3 or 4 senior consultants working. We could have had such replicating units, which would have given hopes to so many children. But definitely, over last 10 years, we have found it wanting, and we need ethical considerations for selecting children for this PDS tenting. The approach, whether it be patient centered care, family centered care, or cultural competence. Various communities that I am fortunate to have worked in various regions of country. I have seen many regions. Some may like to enter that multi-staged surgical treatment for their child. Some may definitely avoid it. Even we screen them at their doorsteps. I have traveled to length and breadth of the country in various hospitals while working, but I have seen this. Mm, they don't like to. Some communities have those customs or beliefs. They will not directly. So we need to build up that cultural rapport and competence so that we get sustained responses from the community where we are working in. And it is important for us to keep the follow up care and provide the care in coming challenges if someone gets complications. In these, the opportunities for collaboration is million. Lot of opportunities we can definitely build up in this discussion group, because I thought I can share a few of my understandings and my own thoughts. Finally, to conclude, this is the need of the hour. We need to build a ethical framework for guidelines for selection of patients for ductal stenting, not only for guidelines for patient selection, but also for the build-up of a team, the group, the community center, so that these children, unlucky children, I feel these are the fringe groups. The main focus at present is on the straightforward biventricular repairs, but definitely these children also form a big chunk of numbers, and we seriously want to take treatment to them. So this is my request, that you please consider formulating a ethical framework for guidelines to patient selection, as well as how to get it done on a wider scale in such a huge hospital group of hospitals that we are working. This is my sincere request. And I thank our chairman sir and our head of the department cardiac surgery, Dr. Ragini Pandey madam, for all the support they have given. And over the years, they have been my mentors in various aspects, not only professional but also personal life. Thankful so much, sir.
Yogesh, thank you so much for that wonderful presentation. I think, one of the things you outlined very well is it's not a patient specific treatment, it's a programmatic
Yes,
decision, right? The whole program needs to be along with it. I think one of the ways this fits into a little bit about Sanjeevani is the women's hospitals now that are coming up, the fetal echoes that are being
mother
brought
and
up,
child
the
hospitals.
mother and child
Yes,
hospitals. And there's going to be patients that come through your diagnoses that are going to be candidates for something like a ductal stent.
yes,
And those are the discussions that needs to be had with those families. I think, so much of what we're seeing probably in the West, is going to transition over here. The parents will have a more educated decision on how they want to go forth, and
yes,
that's a very big decision for them. So I think as this comes through the Sanjeevani system, something like ductal stenting, these things come up every 10 years, and when we first do it, we think it's not going to be the next stage, but already in the US, this has taken over for shunts. We
yes,
rarely do shunts anymore because everything is a ductal stent. And, those patients, you will see a cost. When the stent prices come down, if they come down, we will see a cost benefit, right?
yes.
Because those patients will not stay in the ICU as long.
Hmm.
They won't, have their surgical needs. The next surgery they have will be, potentially, if it's a biventricular type anatomy, it's going to be curative. So just a couple of comments.
Yes, definitely. Stent is one thing which will keep the child's freshness for the first RV2P conduit surgery intact. Surgeons won't struggle like previous BT shunt. They won't struggle to open up again. So stent is a very viable option, and with that's what I need, a dedicated team of co-workers, exclusively pediatric cardiac, who are ethical, who do all the work with passion. Because I got inspired from Dr. KMC, so definitely I want it to be transferred into the generations so that it will be a useful addition to humanitarian mission.
Is in my institution, I am encouraging my interventional pediatric cardiologists, to in favor of the ductal standing. And really, in my experience, I had, many cases of pulmonary atresia with intact septum.
Yes.
And even, in partially tortuous PDAs, where, they were able, to implant stents. And when I see the midterm results with partial resorption of the trabeculation and remodeling of the right ventricle, really, I can say, even, I have cases after 5 6 years with no need for gland anastomosis or the use of homograph, to reconstruct the right ventricular flow tract is spectacular.
Yes, yes.
I am one of the strong believers of the ductal standing, and for a reason, I encourage my intervention pediatric cardiologists. But on the other hand, the cost, why, is so excessive? Because it's related to the material itself or to the procedure. Why? Because you presented, cost similar to surgeries.
Actually, the cost I have referred to the literature review only. The cost for the material will be something around 1 to 2 lakhs in US dollars. For India, it will be around 28 to 30,000 drug eluting stents, because government of India has capped it since maybe 2018 or 19. Before it was quite huge for coronary stents. It will go on for 50,000, 1 lakh. depending upon the type of stents.
And
Now it has
you
been
don't
capped.
have locally manufactured stands because you do
Yes,
everything.
in
Yeah.
Gujarat we have one locally manufacturing
Yeah.
stent unit, but they also fall into that cap. So they
Oh,
have
yeah.
to sell around 28,000 for drug-eluting stents, coronary stents.
Yes.
So
Because you are very competitive, you know.
yes,
I started also implanting, in some exceptional cases, the Merrill valve, the Indian.
Merrill Life. Yes,
Yes, the similar to
they
the
have a
Edwards.
plant in Vadodara,
Yes,
Gujarat,
yeah,
and
yes.
they are manufacturing the coronary
Yeah,
stents in India.
in the mitral position, in the tricuspid position, I was one of the first publishing in the Journal of Thoracic and Cardiovascular Surgery in the
Yes,
tricuspid position, uh, and the quality is good. For this reason, you know, I'm telling why. You know, you don't. You don't tell them, you know, to be more competitive for the Indian children, from the Indian patients, from the
definitely
Indian reality.
definitely for us,
Yeah,
we want to do, but then if we are daily faced with hundreds of OPD in the areas,
yeah,
I have only one cardiologist with me who comes for 4 hours,
yeah.
and I am alone with my students, DRNB students, and we five of us will try to complete the OPD on a daily basis.
Mhm.
I personally cannot go in cath lab. When he is there, then I will be able to spare my time and go to cath lab.
Yeah,
Either he or I will do juggle up.
yeah.
So we are facing this scarcity of
Mhm.
staffing. Uh,
And the
Hopefully,
second point, you know, is this procedure, because when, you know, they started my interventional cardiologist, there was also some complications. The biggest complication is especially the migration of the stent.
yes,
And,
sir.
you know, I had some of those newborns
Yes,
died. Uh, yes,
it
unfortunately.
is a dangerous thing to
Yeah,
happen.
for
Shunt
this
migration,
reason, you know, they were becoming
statement.
a little bit reluctant. But for us surgeons, it's very comfortable, you know, to go over, you know, this period, especially in low uh, low birth weight cases,
Yes,
premature
yes.
cases. Yeah.
It is a contraindication less than 1.5 kg.
Well,
We
fine,
should
but
not be doing.
you have, you know, the 2 kilos,
Yes,
2.5
but
kilos.
then it needs experienced staffing
Yeah,
for doing
but what I
procedures,
wanted
even
to
for 2 kg, 2.5 kg.
yes, it's very
Yes,
expertise dependent, and
yes, yes,
you,
definitely.
yeah,
And because I was there at when hybrid Norwood was done
yeah,
at Cherians way
yes,
back, I think in 2006 7,
yeah,
that time I was there. But then uh, yeah, it definitely needs practice
practice,
to
yes.
continue and
But here, you know, you
excel
don't
in the
have any
process.
problem with volume. You have a lot of cases. Uh,
But then because there was
the
a gap.
acquisition of the expertise should be very fast in India.
Yes, sir. Actually, we had a 4 years gap when
Yeah,
I came in Raipur. We had a 4 years gap. Then
yeah,
I shifted to Palwal. That time I started cats again. Uh, I think personally, on my personal understanding, it needs to be done on a regular basis with someone better than you.
yes,
I understand. I know my limitations. I am humble to accept that
very good.
whatever I learned in Chennai, I could grasp just because I got chances in Palwal Hospital,
Yeah, very good.
where Dr. Munesh Tomar madam helped me. But then, similarly, on similar note, we need to have regularly functioning units doing these skillful works. I consider this a skillful work because we need to have that precision. We should not be misjudging the length of the stent and the point where we have to open up the balloon. Yes, yes, because afterwards you don't have any control to pull back the stent. Yes, yes. Thank you very much, sir. Thank you.
Thank you, Yogesh, for that thought provoking